Hello, my name is Dr. Malhotra. I am a physical medicine and rehabilitation clinical professor for Rutgers, New Jersey Medical School, which is associated with the Kessler residency program. I was a VA New Jersey healthcare system attending for 17 years. I'm now in private practice. And my colleague, the esteemed John Norbury, asked me and Christy Nord to help him present the topic of lifestyle medicine for neuromuscular disease, and I took on nutrition. So I'm grateful for him offering me the opportunity to do this. And we are going to skip through to slide 68, where my part of the presentation began. So we are now on my slides. So as I said, this is about how nutrition might factor into the management of neuromuscular disease. So we have a 67-year-old obese male veteran plumber who was sent for electrodiagnostic testing after 6 months of progressive painless paresthesias only in the feet. He likes walking and doesn't eat meat or sweets. He's a newly diagnosed diabetic, recent hemoglobin A1C of 9.2 without any other past medical history. He has an entirely normal neurological exam otherwise. What's your differential? What electrodiagnostic testing would you perform? Why would you perform that? And which criteria are you using to decide this? So let's start thinking about differential diagnosis. Obviously, this is an obvious diabetic distal symmetric peripheral polyneuropathy case, and I'm trying to emphasize the need to be systematic in your initial thinking. So usually I tell my residents to think, proximal to distal. So is there any intracranial or intraspinal etiologies that might be relevant here? Could this person have bilateral radiculopathy? Could they have bilateral plexopathy? Probably less likely. Peripheral neuropathy. And when we do think of peripheral neuropathy, we should be thinking in terms of mononeuropathies versus polyneuropathies, multiple mononeuropathies versus distal symmetric. Since there's no weakness, it's unlikely to be a motor neuron disease, a neuromuscular junction disorder, or myopathy. And medical stuff can be ruled out since this is being presented by a physiatrist. So I took a poll here and asked, what is the minimum number of nerve conduction studies needed to rule out a diagnosis of typical distal symmetric peripheral polyneuropathy in this patient? There were various answers. It ranged everywhere from 2 to, all the nerve conductions you can do in 3 limbs, 4 limbs. And so what I presented was that in the archives of physical medicine and rehab, and I believe this was published in some other journals as well, there was a consensus statement by what was then called the AAEM, Association of Electrodiagnostic Medicine, the American Academy of Neurology, and the American Academy of Physical Medicine and Rehabilitation. And this was, first author was John England, who's known for peripheral neuropathy research. And they said basically that you need 1 sural sensory and 1 peroneal motor. And that's all you need for distal symmetric peripheral polyneuropathy, according to that consensus statement. If they're normal, you're done. You can't, however, say anything about other diagnoses such as radiculopathy or myopathy, etc. So what should we do now with this patient? Talk to him, maybe? I mean, the report is going to be really easy to write, and this is what I write in these situations. Electrodiagnostic impression, based on the normal sural and peroneal studies at this time, the veteran does not meet the minimal electrodiagnostic criteria for typical distal symmetric peripheral polyneuropathy per the definition for clinical research presented in the 2005 consensus statement. And for clinical impression, bilateral foot paresthesias, despite the absence of abnormalities on physical or electrodiagnostic examination, the veteran was counseled that he is at high risk for developing sensory motor distal symmetric peripheral neuropathy. He was counseled on the etiology of the disease and to incorporate lifestyle modifications. So yeah, the report is really straightforward, but what's the reality of the encounter? The encounter where you're sitting there with the patient. So you're kind of ready to move on to your next patient, But if you look at the patient's face, they've got this now what look on their face. So even if you want to help, you may actually not know what to tell them. As Stephen Covey recommends, focus on your circle of influence rather than the things you can't control. Believe it or not, a lot of what seems obvious to you won't be obvious to the patient. Exploring the context of the patient's life and discussing the context of the diagnosis is something you can offer. So let's revisit the history. So it's true, in the first slide, you found out a number of things on that initial screen. But when you get deeper, it's easy to see how he got to this point. For example, even though he's a licensed plumber, he owns the company and sends his boys out into the field for the actual work. He runs the numbers, schedules appointments, answers the phone, and buys the equipment. So he's pretty much sitting at a desk. He says he likes walking, but only gets about 800 steps a day. He used to walk his dog, but since his dog died, he doesn't take the long walks anymore. Meat can mean many things to many people. So he said he doesn't eat meat. He thought meat only meant beef. Bacon 3 times a day, homemade pasta almost every night with Italian sausage and mozzarella. There might be some things to talk about here. He says, no sweets, but he's drinking tons of high fructose corn syrup throughout the day. He likes these caffeine-free sodas and a bag of chips before bed. He's gained weight in the last 5 years and now has a body mass index of 30. I've taken this from Dr. Stephen Greger's book, but basically body mass index ain't the same when you're looking at one person and another. As you can see on the left, although he's the same height as the gentleman on the right and same weight, there is a difference in abdominal circumference. So these are all risk factors and changes that are in his control. Even though their primary or endocrinologist probably offered a lot of education, it's very likely that the patient wasn't either listening or didn't grasp it or didn't think it was actionable information. So I personally usually start by discussing the etiology of their numbers in lay terms. You can use this lock and key metaphor of insulin's effect on muscle glucose uptake. Basically, the door is locked until insulin unlocks the door for cells to take up glucose. If you don't have enough insulin, or if it's bad insulin, or the locks are gummed up, which we'll talk about more later, or you have too much sugar in the blood to begin with, then it's going to hang out in the blood and cause all sorts of problems, like with the vasa nervorum. Saturated fat has been shown to gum up the locks. Yes, when calorie controlled, saturated fat caused more insulin insensitivity than carbs. There's the spillover effect, used to explain how obesity contributes to elevated lipids. Basically, if you're fat, your adipose cells are busting at the seams trying to contain all the fat. So it's constantly spilling over into your bloodstream, even if you didn't just eat a fatty meal. Your muscles are important for taking up the sugar that's in your blood. After frequent conditioning, the nucleus sends more glucose transporters to the cell membrane, making the cell membrane more efficient with glucose uptake. So exercise is like Mother Nature's metformin. Most importantly, type 2 diabetes can be reversed. So you need to start becoming their cheerleader with some form of "you can do this." And when that happens, it's a very different discussion. So you're probably thinking, that's all well and good, but I'm not this patient's primary or even their endocrinologist. I deal with nerves. Well, yes, but have you told them that lifestyle modifications can contribute to curing diabetic neuropathy? In a 1994 study, 21 participants in a residential program were made to exercise for 25 days. 17 of them felt relief within days. Their numbness improved, they lost 10 pounds, dropped sugars, insulin needs dropped, and some were even cured off their meds in less than a month, despite decades with the diagnosis. In 2006, 32 patients received individualized counseling with goals of reducing weight by 7% and increasing weekly exercise to 150 minutes. Dietary counseling occurred quarterly, and they were taught to adjust their home exercise effort based on sufficient exertion to limit casual conversation. They were followed for a year and found to have improvements in glucose tolerance, body weight, cholesterol levels, and intraepidermal nerve fiber density and foot sweat volume. 35 patients over 20 weeks were followed with painful diabetic neuropathy, and they were randomly assigned to 2 groups. The intervention group was asked to follow a low-fat, plant-based diet with weekly classes for support in following the prescribed diet, and to take a vitamin B12 supplement, while the control group took only the B12 supplement. Significant decreases were seen in body weight, BMI, and hemoglobin A1C in the intervention group only. Electrochemical skin conductance in the foot declined in the control group, but stayed essentially constant in the intervention group, suggesting that the intervention may have slowed or halted pseudomotor nerve function decline. Significant improvements in pain were observed in the intervention group, as measured by the Quality of Life Questionnaire, short form McGill Pain Questionnaire, and another questionnaire. Improvements in self-reported worst pain were observed in the control group, and improvements in neuropathy total symptom score were observed in both groups. So what I tell them when they ask me, hey, I'm in pain, exercising is tough. I tell them, well, if you want to lose weight, you have to limit how much you put into your body. Exercise is great for other reasons, but you won't lose weight that way. That's what the medical literature tells us. Now, I realize that is an oversimplification, and weight gain and weight loss is not entirely a thermodynamic equation, and there are complicated mechanisms of endocrine abnormality that are still being looked at. But we also have enough literature to say that caloric intake restriction will lead to weight loss. This is not my slide. This is Dr. Norbury's, and he says, to put it simply, abs are first made in the kitchen, not in the gym. And I'm now going to share a little bit of my own personal experience with you. I was diagnosed with diabetes, an insanely high A1C was found on just incidental testing, and I had to immediately change a lot of lifestyle choices, make a lot of lifestyle choices, and change a lot of habits in my life. I followed Dr. Michael Greger's website, nutritionfacts.org, for many years, so I knew what I needed to do. I just hadn't done it. So first thing I did was no more saturated fats whatsoever. I was eating bacon 3 times a day, and I can tell you I miss it very much. So this is all advice I give people based on my own experience. I love eating. I love masticating, which is the act of chewing. I like stuffing my face. So what I did was I tried to find things that would allow me to do that are low calorie. So unprocessed whole plant-based foods are the way to go, and eating as many legumes as possible. I give my wife a lot of credit for figuring out lots of recipes using soy products. I also found that having a bowl of nuts or a can of nuts in my car to reach for every time I'm driving past KFC or White Castle was also helpful to keep me from driving through the drive-thru and eating all of that. Another thing was I was eating a bag of chips every night before I went to sleep while we'd watch TV. Not good for you. And I also tried to incorporate intermittent fasting, which right now they're saying 16 hours is the way to go. The more you fast, the better you are. The literature's mixed in terms of how safe it is for diabetics, though. And increased my steps from basically being at a desk all day to putting in intentional walking time. Activity is difficult, and doing it after the meal was especially helpful, and I'll tell you why in a moment. That getting a continuous glucose monitor, or CGM, is helpful with figuring that out. So what is CGM? A continuous glucose monitor is basically that button that you see there on the person's arm. Sticks a little filament down there, and a little enzymatic reaction occurs, and it can do this for a certain number of days. We're up to 2 weeks now, And we used to have to use that little machine that they're showing you there. Nowadays, you can have your phone connect wirelessly to the button, and it tells you what your sugars have been for the last however many hours. So this continuous glucose monitoring can be really, really useful for looking at trends. It's not as quick as blood glucose monitoring, because this is looking at your interstitial fluid, but it does certainly tell you about trends. And I found that there was a lot of variability in my response to foods that were supposed to be good for me. So for example, in the morning, eating steel-cut oatmeal actually had a really bad effect on my sugars, and they would climb. So we switched to more protein-based breakfast. And I got to tell you, the way I found this out was I was discussing this with the Walgreens, my Walgreens salesperson. I said, well, what's the greatest way to do the finger sticks? What's the least painful? I did not want to stick my finger. And somehow it came up, CGM exists, and that most insurances don't pay for it, but mine did. So in the matter of 2 months, I was able to figure out all the foods that were, and all the timings of the foods that were increasing my levels, and when to time my walks, when to time certain activities, and whether things I was feeling really were hypoglycemia or not. So this is actually what I tell my patients, and there is some overlap with some of the other slides, but basically find a way to count the calories, or get an app like the Weight Watchers app, or there's a free My Workout Buddy, there's a couple of different apps that you can use to basically follow your how many calories you're taking with each meal. No more high fructose corn syrup or sugar. It's a chemical that is not naturally occurring. No more processed starches. If it's white, it's probably not good for your diabetes. So white bread, rice, white pasta, you can substitute that with chickpea-based pasta. No potatoes or potato chips. Cut the saturated fats. That means actually reading the nutrition facts on the side of what you're eating. And if you love eating like I do, like I said, just stuff your face with other stuff. My advice is to allow for one cheat meal per week. And that cheat meal shouldn't be crazy, but at least you have this sense of control over your do's and don'ts, and it's your decision. So if you are meeting with friends and you are going to eat that one dessert that week, at least you're not feeling guilty about it because you've allowed yourself one. I'm a huge fan of Dr. Michael Greger. He has this website called nutritionfacts.org, and he presents the science. It's the science he wants to present, but he does do it without a specific moral of the story. Most of it does tend to be favoring whole plant-based, unprocessed foods. But I learned so much from his videos, and I think he's great. So I took a little sidetrack here and asked the audience, we often hear people talk about the healthcare crisis. So what is the healthcare crisis? And I took a poll. People raised their hands, and I heard things that ranged from, the opioid epidemic, suicide rate, lack of access to primary care, rising comorbid chronic healthcare conditions, the rising costs. And, what the healthcare crisis really is, and our nation is facing one, is we spend close to 20% of our gross national product on healthcare and still have poor outcomes. 75% of all of our costs are related to chronic conditions, which in large part are driven by health behaviors: what we eat, how physically active we are, whether we smoke, how we manage or don't manage our stress, etc. Several decades ago, infection was the leading cause of mortality. Then antibiotic pills solved the problem. So find it, fix it. Historically, this was a great development, but our current problems and current causes of mortality are more complex these days. So notice in this pie chart from the CDC, breaking down all factors contributing to health, that social and economic factors is the largest piece. The next largest piece of the pie is health behaviors at 30%. Clinical care, where most of us most of us in this environment spend our time and energy throughout our careers, it's only 10% of the pie. So in response to this, to try and answer this, in 2015, a bunch of people much smarter than me, the Institute for Healthcare Improvement, suggested 10 new rules to accelerate healthcare redesign. So anyone wanting to redesign the system would want to think about these things. Now, when I presented this, I was in the VA, and I wanted to point out that the VA was already doing a lot of this. Balance of power. So the VHA already had embraced patient-centered care, which means we recognize there's more than one expert in the room. We value focusing on what matters to the individual rather than what's the matter with you. Promote well-being, promote health and happiness, and recognizing that the patient may not need healthcare. Promoting joy and pride in our work, resulting in better patient and economic outcomes, which would be increased patient satisfaction, less hospitalization, less turnover with staff. Standardize what makes sense. Make it easy. Continually substitute better alternatives for visits and institutional stays. Eliminate silos and tear down self-protective institutional or professional boundaries that impede flow and responsiveness. Especially assume abundance, especially those assets brought by veterans, families, and the community, and return the money. And guess what? The VA was already going there, innovating, piloting, and studying how to make this system real. In 2013, the Office of Patient-Centered Care and Cultural Transformation was created to help VA realize this vision of a new kind of healthcare system. VA is developing infrastructure, coding, documentation, and a reimbursement plan so it can be more realistic. The healthcare crisis in the United States has led to a call for transformation to a proactive model of care, and VA has the opportunity to become the national leader in whole healthcare delivery, and the whole health partnership model is a roadmap to this paradigm shift. Whole health is a systematic approach developed by the Office of Patient-Centered Care and Cultural Transformation in collaboration with the Veteran Experience Committee and endorsed by the National Leadership Council. It emphasizes self-care in the larger context of well-being and incorporating a full range of conventional and complementary and integrative health approaches. Whole health was trying to move VA from focusing on episodic care to a more continuous engagement with the veteran throughout his or her life, including early in the relationship between the VA and the veteran. Whole health is about creating a bigger system to support this creation of health, not just asking one small group of people like primary care teams to do this work. Initial pilot work helped us learn that doing it all in primary care, was not a feasible model. We need to engage the biggest parts of the system, our patients, their families, and communities. Bottom line, it's not a program that has a separate department with separate support staff and providers. It's a way of being. It's a way of care. On the right here is a picture of the whole health system. There are 3 parts, 3 ways for veterans to be supported. Each part of the system has its main intention: to empower, to equip, and to treat. And all the parts of the whole health system are always aligning with what matters most to the veteran, which is represented by a personal health plan in the center. The personal health plan is the integrator across all 3 parts of the system. Its design is to ensure everyone understands what really matters to the veteran and what their health goals are and how all parts of the system can work together in support of this. Different people engage in their health and with healthcare in different ways. While some may want or need to engage fully in clinical care, others may not, but may still be interested in thinking about their health and working on their health goals. Others may want to explore the idea of what their own health and wellness means to them and the things they can that can impact this. The Circle of Health is a proactive tool for veterans to explore their overall health and well-being. Based on the veteran's values and preference, the Circle of Health can be used in all 3 areas of the whole health system. It's a way to make them think about their own whole health. All of the areas in the circle are important and connected. Improving one area can benefit other areas in an individual's life and influence their overall physical, emotional, and mental health and well-being. The human body and mind have tremendous capacity to heal, and these innate healing abilities are strengthened or weakened by what an individual does. By having this as a tool, it's a way to open communication and develop a better partnership between veterans and providers. So that's what I had presented, and I hope it helped you in some way. Thank you.